So the third case of this session is the recorded case. Vivek Reddy will show us a case of linear lesions using a 122 electrode spherical array.
Thank you very much, Mr. Okay. My disclosures. Now, this device does have regulatory approval in both Europe and the United States. But the approval in the United States is mainly for PVI isolation. What we're going to show today is PVI isolation, but also linear lesions, and that would be off-label use, just to let you know. So let me just describe the device. I'm going to send a couple of slides, and I think it's worth describing since this is potentially quite practical for some. The device itself is as you'll see, it's a multi-electrode spherical array. There's a total of 122 individually selectable electrodes, and you see each of them here. It has the ability to detect contact, and it uses two different types of scans, and we'll show you that. You can individually select the electrodes for targeting, so you identify which electrodes are touching tissue. You select which ones you want to deliver energy from, and then you deliver the energy. It actually has the potential to deliver both radio frequency and pulse field energy. Though in the United States, the regulatory approval, I'm pretty sure, is only for pulse field. And it also can deliver single-shot lesions. It was recently studied in a FDA pivotal trial, and it showed very high efficacy and actually very high durable PVI isolation, even in those patients that came back for second procedures, 95%. So let's just go through a few aspects. Once the device is touching tissue on the system, and we'll see examples of that, you can select different lesion sets. For example, if you're the ostium of a pulmonary vein, for example, you can select lesions to deliver in a circular manner. And we usually select two rows, so one row, second row circumferentially. You could do a horseshoe, for example. Let's say it's a large common vein. Then you can push it up on the top, deliver a horseshoe on the top, put it on the bottom, and complete the lesion. You could deliver focal lesions. Let's say there's a focal tachycardia that you map. This also you could map, by the way. And you can deliver linear lesions, which is really what we're going to focus on today. Let's say you're on the posterior wall and want to ablate the whole region. This should make Luigi very happy, I think. It is directional electroporation because the way these electrodes are designed, there's a stainless steel rib on the backside, an insulator, and then it delivers energy directly into the tissue. So the backside is insulated, so it will be directional. So if you're touching tissue, then you expect to have pretty much very minimal hemolysis. And of course, this is different from other sort of conventional electrodes. Now, when we talk about contact, it has two contact sensing strategies. One they call the flow map, and the other one is called the other map, and we'll get to that. But this is the flow map, and this is what we use when you're actively manipulating the catheter within the chamber, because and you can actually see it on here. The white represents contact with tissue. The dark black represents, well, just blood pool. And the way it does this, it measures cooling of the electrodes. So it's delivering a very small, well, actually, it's just dynamically looking at the electrodes as they're cooling. Because if it's blood, it gets cooled very quickly. If it's tissue, then the temperature starts to go up. Now, this is pretty good at detecting contact. It's good enough that as you're manipulating around, you can say, oh, look, I'm here at the ostium of the pulmonary vein. But if you then decide I want to deliver a lesion there, then what we want to do is do what's called the contact scan. So the flow map is a dynamic thing that you get real-time information. The contact scan uses a different strategy. It injects a small amount of energy through the electrodes to heat up the tissue, and it measures the rate of electrode heating. If you're touching tissue, the rate would be higher than if it's in the blood. So let's just run that one more time. So you start the contact scan. It's running the scan right now. It's thinking I have contact here. And over the course of about 8 to 10 seconds, it says, okay, this is the area. And then it can select, it gives you some options in terms of electrodes. And let's just pause it. Just pause it there. These green represent electrodes that you're delivering energy into. So let's just look at the recorded case. It's a 64-year-old male with persistent atrial fibrillation who's planned for an ablation procedure. And this is a protocol in which, in addition to PVI isolation, we also, in this particular case, do linear lesions. First thing is introduction. So this is the assembly. There's a deflectable sheath here. And here you can see it's being extruded out of the out in the left atrium. I like to always look at it with ice because then you have a very easy understanding of where the device is relative to the anatomy. And then when you rotate this knob, it becomes the actual globe. And now you're ready to map. So here we're going to manipulate the device. Actually, let me just go back one step here. Let me pause here for 1 second. If you look at here, this is the sheath is here. This is the actual device here. In this case, we have a coronary sinus catheter also. As you sweep it around within the chamber, you can create an electro-anatomical map. The other thing is, people look at this and say, "Oh my gosh, this is so big." Just remember, this is the same size as a cryoballoon, which is what I think many people are used to. And I think this is an extremely safe device in terms of manipulation. In fact, in the pivotal trial, we had actually 0 safety events related to the device. So you're manipulating within the chamber. You can create a map. In this case, you can also have electrograms, and we're going to run a contact scan. I think this is up against, well, it says right here, left inferior pulmonary vein. There you have the electrodes, then you can select this, and at this point the operator can deselect electrodes or select additional electrodes and then start delivering energy.
Vivek, can we pause for a second?
Yeah. I'm just going to let this run because I actually want to focus on something else.
This is a catheter that allows mapping, contact sensing, selective electrode ablation. Andre, where do you think this will fit in what we have now? What does it add? Is there any unmet need that this catheter would fill?
That's what I'm thinking, Musa. I'm trying to understand. And of course, I have no experience with the catheter. What is intriguing and very interesting here is that it seems that the durability of the lesion is quite significant, right? And if Vivek's saying that, it's easy and safe to manipulate, I think seems like for the initial case, for the initial approach of patients with atrial fibrillation, seems an okay option there.
Yeah. So and again, it is easy to manipulate, but it's a little bit unusual when you first manipulate the catheter. But people learn very quickly. And I do want to say, in the pivotal trial, most of the operators had never touched this, and even then, the rate of durability was really high. It's the highest I've ever seen in a pivotal trial. Anyway, so here it's a left superior.
Vivek, let's talk about that a little bit. So for very high rate of durable PV isolation, do you think that's a function of the contact sensing, the ability to decide where you want to ablate, or the waveform itself?
I think it's contact sensing. I think that when you really are in a good position and you prove to yourself you have apposition with all the electrodes, you get very high durability. I mean, we saw this in the first in human trials with Peter when we were doing remapping studies, certainly in the preclinical work. And even here, again, I want to just stress this. I'm going to make up the numbers, somewhere between 10 to 15 patients that came back for redo ablation procedures in the pivotal trial. So these are patients that had clinical recurrences, okay? And despite that, the PVI durability was like mid-90s. It's pretty good.
Do you want to comment, Vivek, on what this cannot do? Are there places you cannot get easily, or you'd say
you probably can't get in the coronary sinus very easily. I wouldn't put it in the ventricle very seriously. But having said that, we did put it in the right atrium. As I'm going to show you that in just a second.
Yep.
So I think in the atria you can get pretty much all the areas we care about. Yeah. Okay, so let's just do this. This is the first interesting thing. So this patient, we're going to do a mitral isthmus line here. So if you look on this view here, left lateral view, these are the PVI lesion sets. We're positioning it here at the mitral annular region. And then what we can do is we're running a contact scan here. And then we can select the electrodes that we want to deliver from these electrodes here. Again, this is easier to see when you see it on the map. So you can see right here, these electrodes you want to touch. So you select it, it's in good contact, and then we start delivering energy, and we're going to start ablating here. And at the end, you can do a voltage map really quickly, though obviously acute voltage changes after PFA is of questionable significance. Then we want to go a little bit more laterally. So here we're going to counterclock the device a little bit and position it closer toward the annulus. So we got this region and this region. And again, I think contact here is critical. I think the most important fact, or the most important issue in my mind for lateral mitral isthmus ablation is stability and contact. I think that's the issue. It's not tissue thickness.
Do you give nitroglycerin in this area?
Yeah, we typically, for these, unless you're doing RF. And then we pick more, and then we deliver energy. And let's get past this. And then what's really nice is you can pace from the coronary sinus, for example, and look at change in activation. Or you could, if you could put this on right here, you can pace from one side and look at activation on the other side. Now, in this particular case, I believe, yeah, okay. And then afterwards, what we're doing here is just doing an activation map. So here it's sped up a little bit, obviously, but we're manipulating the chamber, the device within the chamber, and we'll see what it looks like at the end here. So this is an anterior view. This is a top-down view. This is anterior, and this is posterior. And we can see the activation. And the other view that they like to show is sort of the global view, which you're going to see in just one second. Because it's a little weird, but I'm starting to like it. Yeah, this is the one. So just to show what this is opened up at the level of the mitral valve. So this on the outside is the mitral valve, okay? There are veins here, and let me just play this here. And what's happening is you have activation that's percolating here and blocking. Oh, come on, let's do that one more time. Okay. Activation, and it blocks right here. This is the point of the mitral block. It looks like it's going round and round, and I guess if it looks like that, Andre wants to ablate it. But it was actually just pacing on one side of the line, and activation was going around. Now we're going to go to the right atrium. So we pulled it back in the right atrium. We deploy this. So as you take it out, I tend to point it laterally, toward the lateral right atrium. Then we open it up, and now it's deployed into the sphere. And then we can deflect it. I'm going to jump forward a little bit, interest of time. So here maybe I'll go back 1 second. Okay. Oh, I already deflected it. So it's deflected, and we deflected it. It's on the CT isthmus. You can see the tricuspid valve there. We'll run a contact scan here. And so we'll see that there's, so this is voltage map, and this is the contact scan. And then we can select, and again, we like to select 2 rows of electrodes, whether it's PVI or linear lesion or whatever. You can also, by the way, select any of those electrodes and look at the electrograms during any of the tachycardias or whatever. So we're going to put this in this location, and here, once we like the location, here we actually deliver RF energy. That's the red right here, I think. Is that right? I'm pretty sure we did. Yeah, we did RF ablation. So in this instance, I don't know where he is, but anyway, in this instance, we don't give nitro, obviously. So on the tricuspid side, we deliver RF lesion. Then we pull back, deflect. Now, I should say, when you deliver RF, the way this system works is not irrigated. It basically heats up to an ablative level, and it just waits. Okay, so time is what the system uses in order to let the heat percolate into the tissue, because they're wide electrodes, so your heating element is big, and that allows you to project. What's the downside? Time. So the lesion is much longer. It's like a 2-minute lesion or something. So that I don't like. So then we can pull back a little bit, select the rows for the PF, and then deliver the pulse field energy. And then again, in just a time, I think we go back one more. So we did a total of here are all the lesions, and then we can put the globe on one side and pace and prove to ourselves that we have block. Sorry, let me just see here. Oh, we're delivering the last PF. Okay, that's what it was, yeah. So we pull back here all the way to the IVC edge that you see here. And one nice thing is that because you have electrodes everywhere, as you pull back, you can ablate on the electrodes on the back end, for example. And then we're going to do, what is this, another contact scan. Select the electrodes again. Deliver pulse field again. And finally, we can do pacing. So we can pace and then measure the distance here to the other side. Again, you can select any electrodes that you want here. You can actually pace, by the way, from any of the electrodes too. So you could, for example, if in some instances you can actually put the array just on the line, pace from one side, and look at activation on the other side. You can't always do that because you've got to have enough electrodes with potentials to be able to do that, but sometimes you can.
So
Well,
Vivek,
you made it sound like very easy.
What's that?
You made it look like it's very easy to do.
It is.
Well, it's like in most things, you have to learn how to manipulate it. It is big, but once you learn that, it's actually not that difficult. And the difficulty of catheter stability and the difficulty of electrode, that stuff is all gone. The complexity is in the catheter, but they took care of that for you.
It's choosing the electrodes of contact.
Yeah, I mean, it's not difficult. That's obviously straightforward, but yeah.
Very nice.
Actually, it is interesting that the majority of the patients were done in deep sedation.
Yeah,
So
good
we
point.
are not using anesthesia anymore, and because of the stability of the catheter, I mean, the sphere is like very, very robust. I mean, optically robust, but it's advantage because it stays there even like on the PV side, on the mitral side, on the CTI. Okay, it's a very stable catheter.
Yeah, that's a very good point. Many of these cases, we don't have to use general anesthesia. And I think part of that is, again, the directional ablation.
SVC?
Good question. We have put it there. I have not ablated there. But, you could, because you put it there, you can see where the sinus node is, right?
I'm asking
Because of
you cannot
activation,
change
and then put it in a different
you cannot
location.
change the size of the balloon, right? It depends.
Well, I mean, just to be clear, you can't put it in the SVC, but you can push it up to the roof where the SVC is, right? That we've done. And then what I'm saying is that you could map in sinus, identify where the sinus node is, and just select electrodes away from it, so that way you don't hit the sinus.
And when you're showing the left atrial map, those veins are fake veins, right? You're not.
Yeah. Good point. Yeah. So that's for. Let me just put that up here because I think that's a really important point. So these little tubes here. Obviously, we didn't put the balloon inside of the veins. This is just sort of a. Remember the old Cardo system with the little tubes? Well, it's sort of like that, just to make it easier to understand where things are.
And it's based on that no contact region in the center? Is that how you decide where the vein is?
Yes, that's right. And it looks a little weird, but after a couple cases, I think it's pretty straightforward. Look, time from first to last PVI was 7 minutes. The left atrial dwell time was, well, you see what it is.
So, Vivek, we have 2 minutes left. We'll give Peter a question or
I need to
comment.
add something funny because remember yesterday we discussed with Boris. I don't know, Boris is somewhere here. Actually, poor Germany, they have no any eyes, right? Because they have no money for eyes. And actually, it's interesting that the globe, I believe, we can use even without eyes. So if you have no eyes, because the contact information is so good, you have idle positioning of like PV, everything. So you can just visualize by the sphere, globe itself.
Yeah.
So this is some advantage for poor Germany.
Yeah, in fact, a lot of the initial work with this system, because initially it started off as a pure RF system. Yes. A lot of the work, Hans Kottkamp and Gerhard Hendricks did a lot of the initial work with the technology. And it was in Germany and Switzerland, and apparently they didn't use ice. Let me just show a couple of things. This is from, the clinical trial, the IDE trial, in case you are interested. The primary safety event rate was very low. The only complication was a patient who had a hemorrhagic stroke, completely unrelated to the procedure, obviously. And all of the, even vascular bleeds, because you think, oh, it's a big puncture. No, it was good. This is what I was talking about, durability, compared to other pivotal trials as well as other experiences from large registries. And again, in the repeat ablation procedures, clinically driven, excellent durability. And the efficacy was also quite good. And the number of applications per vein. Anyway, I'll just leave it right here.
And Vivek, the hemorrhagic stroke, anything to do with the eventually higher INR?
No, it isn't. You know what it was? It's
No,
interesting. That patient had polycystic kidney disease, and it turns out that they have a higher incidence of hemorrhagic telangiectasias, et cetera. And
the ACT is regular?
Regular, just whatever you normally do. Between 350, something like that. The device actually is heparin coated, as it turns out. Thank you very much.